сегодняшнем нашем вечернем симпозиуме компании Novartis, который посвящен персонализированной терапии меланомы. И с огромным удовольствием, вообще это большая честь для меня, представлять здесь Дирка Schadendorfa, одного из ведущих экспертов в мире по лечению меланомы, который расскажет нам о эволюции современной лекарственной терапии меланомы. Ну, конечно, сегодня меланома – это просто реально революционная история на протяжении последних меньше чем 10 лет, которая из ничего вдруг превратилась из такой вот золушки, можно сказать, превратилась в эту красавицу. Конечно, такое не совсем, может быть, идеальное сравнение, но, тем не менее, еще несколько лет назад у нас фактически не было ничего для лечения этой болезни, а сегодня есть много различных опций, и с огромным удовольствием еще раз представляю доктора Schadendorfa с докладом, посвященным вообще эволюции терапии современной меланомы. Please, Dirk.
Dear Chairman, ladies and gentlemen, thank you for the invitation to Novartis, and it's a pleasure to be here to give you some overview on what has changed over the last decades in melanoma. And actually a lot of things have changed, and that's part of the reason why you're probably here. So we have seen after decades of clinical trials which were not successful, not reaching their clinical endpoints. We have seen a lot of new agents coming, having produced positive clinical trials and are also registered and reimbursed in malignant melanoma. And you see here the names we have. We are starting 30 years ago with dacarbazine and alkylating agents, and then with the discovery of the BRAF mutation opening the door for targeted therapy in melanoma, and with the drugs approved. And the second new leg, which is immunotherapy, has started 15 years ago with its development, ipilimumab as a first checkpoint inhibitor, and then PD-1 antibodies which have reached the market. So let's have a brief look backwards. We have seen single agent chemotherapy and also combinations of chemotherapy. We have different classes of chemotherapy which have been used for decades in patients: alkylating agent, urea-derived agent, platinum-based agents. And what is all in common is that all these agents were not able to prolong overall survival in all the clinical trials which have been done to more than a year. We have had overall response rates in the range of 15%, 5 to 15%. But all these patients who got treated, the 1 year overall survival rate was in the range of 30%. And none of these clinical trials which have been performed with all these agents, in comparison to placebo, never showed any clinical benefit in terms of prolonging overall survival. And the same is actually true not only for single chemotherapy agents, but also for combinations. And here are some of the combinations which have been used in the past quite frequently. Actually, what we have learned is that adding chemotherapy to each other is increasing toxicity. You know that this is true not only for melanoma, but in melanoma there was no increase in clinical efficacy. And this is one example from the history published 20 years ago. And you see that monotherapy, DTIC, and the combination of various chemotherapies defined as Dartmouth mouse regimen, the survival curves are completely overlapping. So there is no increased overall survival benefit. You see that the median overall survival in this patient cohort was in the range of 7 months, 6 to 7 months. And the only thing what we have achieved using polychemotherapy is increased toxicity, bone marrow toxicities, fatigue and nausea, for example. So one option which was popular in the last 20 years was also high-dose IL-2, which was pioneered at the NIH by Steven Rosenberg and got approval in the US. And the only country in Europe, it was Denmark who got approval based on a series of phase 2 studies using this high-dose IL-2. And the reason for that was actually what is shown here, that there was a subset of patients who had a clinical response, sometimes even a complete clinical response, and that those patients had a long duration of response. And you see this is here a very long scale in the follow-up time, so it's a duration of response for years. Although the entire population which was treated, the median overall survival was only 11.4 months, as you can see, and the response rate was low in the range of 15%. Those patients achieving a complete response had a very long duration. So this was actually the birth of tumor immunology and the dogma that if you are changing the tumor environment, if you are treating patients with immune oncological agents, that in a small subset of patients, this might be a durable response, leading possibly even to cure. And coming back to the options we had for years, this is a summary which was published in Lancet Oncology 15 years ago by Thomas Eigler and Klaus Garbe. And you see that on the left-hand panel, you see an increase in overall response rates with a large overlapping confidence intervals, but the median overall survival is not different. Whatever you do, whether you are looking for single agents or for polychemotherapies. So clear message, there is no real benefit. So that's the reason why in the beginning of this century, DTIC was chosen as a reference as agent and as some sort of poor standard for all the registration studies which were done thereafter. One of the first and the first prospectively randomized clinical trial which showed a positive clinical outcome and subsequently was published in the New England Journal was this study, demonstrating for the first time that there is an improved overall survival for ipilimumab, the checkpoint inhibitor ipilimumab, in a prospectively randomized clinical trial in metastatic melanoma. And you see the two arms who got treated with ipilimumab overlapping in blue and in red, in comparison to more or less a control, which was a GP100 peptide, an experimental arm. And there is a clear discrimination between both curves, as you can see. And this difference was maintained over time. But if you look at the overall response rate, you see it's just 10 to 15%, like DTIC. The median PFS, progression-free survival time, between 2 to 3 months, like DTIC, and the overall survival, 10 to 11 months, like DTIC. So the difference is actually that there is a long tail in the curve and that there is a subset of patients who is surviving. And this is actually the new thing which is exciting in checkpoint blockade. But there was, in parallel, a very exciting study and story which is emerging, and this was the discovery of a mutation in the BRAF gene, and this is an original publication which was done only 15 years ago in Nature 2002. And this mutation is not only, as you know also today, not only present in melanoma, it's also present in various other tumors, but the frequency of mutation is almost 50% in melanoma, and therefore it was paradigmatic to use this mutation in melanoma to develop drugs. And there is one specific mutation, the V600E mutation, which is most prominent in these patients, in which is associated with a gain of function and is defining a driver mutation. So BRAF is a driver mutation in melanocytic cells, which is affecting the MAP kinase pathway. And just a couple years later, we were able to demonstrate that vemurafenib, as a first prototype BRAF inhibitor, as a monotherapy, was able to prolong overall survival in BRAF V600E mutations. And I think this was also the first landmark study, only a few months later, demonstrating that also targeting this MAP kinase pathway with a mutant BRAF, that this has a major impact on overall survival, on all aspects of treating this disease. And you see here that this impact is seen in progression-free survival in comparison to DTIC as a comparator, which is quite striking. And this also translates into an overall survival benefit using vemurafenib, and made vemurafenib at that time, around 2012, as a new standard for patients having a BRAF mutation. And the same is actually true for dabrafenib. Only a few months later, also results for dabrafenib as a monotherapy in the BREAK3 study were published and presented. And you see very comparable PFS data in the range of 7 months, and a median overall survival you could achieve with dabrafenib in the range of 18.2 months, so almost doubling the overall survival type in patients who otherwise would have been treated with DTIC. In this trial, you see survival for DTIC-treated patients is higher, 15.6 months, because patients were allowed to cross over to active treatment after disease progression. I think this was a very interesting observation, that obviously also BRAF inhibition is working in second and third line treatment. And if we look at the treatment allocation, you see that those patients who got treated with DTIC initially, almost 70% of these patients crossed over to targeted therapy subsequently, explaining this excellent overall survival for patients initially treated with DTIC. So we have subsequently, obviously, also therapies with PD-1 monotherapies, and this is one example. This was Checkmate 66 using nivolumab in BRAF wild-type patients. So in those patients who had no treatment option, the trial design in 2013-2014 was actually comparing nivolumab against DTIC. As an option with a primary endpoint of overall survival. And here you see the overall response rate. The response rate for nivolumab was close to 43%, for DTIC close to 15%, which is already statistically significant different, but also the percentage of complete responders and partial responders are much higher than those with dacarbazine, which was probably not surprising. And these are data which have only recently published 2 or 3 weeks ago in JAMA Oncology by Paolo Ascerto, with an update of more than 3 years now. And you see that overall survival now is 30% different in those patients initially treated with nivolumab, 51%, in comparison to 22% for DTIC after 3 years. And if we look at progression-free survival, the true effect of the drug, you see roughly 1/3 of the patient is still maintained in without tumor progression using a PD-1 antibody in comparison to 3% with an alkylating agent, which is actually mirroring our clinical experience as well. And this is true not only for nivolumab, just for balance. Here also some data with pembrolizumab, and you see progression-free survival and overall survival in the KEYNOTE-006 is very comparable to what we have seen with nivolumab in comparison to DTIC. Here the comparator is ipilimumab, but also PD-1 in monotherapy is superior to ipilimumab as a second take-home message for that space of PD-1 monotherapy. Then the famous Checkmate 67 study, which was initially published 2015 by James Larkin in the New England Journal, and this is obviously a comparison of ipilimumab monotherapy, nivolumab monotherapy, and the combination of nivolumab and ipilimumab as a combination. 300 plus patients in each arm, overall survival and progression-free survival as primary endpoints. And this study has been updated several times. The latest update is shown here, which was presented at ESMO 3 weeks ago in Munich. And you see we have now 4-year rates, 4-year landmarks, and this is shown here for progression-free survival. And after 4 years, you see that the difference, that there's here some sort of plateau for the PD-1-based therapies, combination on top, monotherapy after, 4% difference, 7% difference, 6% difference in favor of the combination. Clear benefit in comparison to ipilimumab, and this is also statistically different if you compare monotherapy PD-1 to the combination. If we look at the overall survival, you see the difference is still visible around 5, and here we have a 7% difference overall survival benefit. This comparison here in terms of overall survival is not statistically significant, but still there is a numerical advantage of the combination with some toxicity, and you all know that the combination of a PD-1 antibody plus a CTLA-4 antibody is associated with toxicity. We have roughly 60% of patients suffering from treatment-related AEs, grade 3 or 4 in the combination arm, and roughly 40% of the patients have to discontinue treatment. And that's actually something in the hands only of experienced centers and doctors, also coping with a grade 3 toxicity, which can be life-threatening if that's not handled carefully enough. So moving back to the landscape of genetic alterations in melanoma, and we know that BRAF but also NRAS are mutated quite frequently in melanoma. Both are driving the MAP kinase pathway, and obviously this pathway seems to be of critical importance for this disease, and we know that inhibiting, and I have shown you the clinical data using monotherapy of BRAF, is producing clinical activities but also side effects. If we look at the BRAF wild-type patients, for example, cells, keratinocytes and other normal cells in the body. And so the idea was, combining BRAF and MEK together in order to improve response rates, to delay resistance, and also improve overall survival. And in parallel, in normal cells, you would expect that this dual MAP kinase inhibition would lead to a reduced toxicity because you are eliminating this paradoxical MAP kinase activation, which is shown here in red, by the addition of the MEK inhibitor. I mean, you have seen possibly this slide already several times before. The power of BRAF inhibition demonstrated by this PET-CT scanning, and you see that within days this metabolic activity is shut down and demonstrating that there is an immediate effect on the tumor in those patients. One of the major problems, obviously, especially if you use a monotherapy of a BRAF inhibitor only, is that you are getting success quite easily in a large fraction of patients, but there is also some patients who have a relapse within a year. And this resistance using monotherapy of a BRAF inhibitor, the idea is combining BRAF-MEK, this can be prevented. And just to have some data which are associated with what I said, looking at the summary of adverse events here on this slide, and this is a comparison of COMBI-D and the COMBI-V, just to show you that the monotherapy, and here vemurafenib, here dabrafenib, that the AEs leading to permanent discontinuation of study drug is very comparable. There is no major difference. And so adding a second drug is not adding additional toxicity. In some ways, it's eliminating some of the toxicities. And that's a clear contrast to adding different chemotherapy drugs together. So just to summarize, I think it's important that using a dual inhibition of the MAP kinase pathway, it's important to hit the target, the BRAF mutation, to hit it hard. So don't use monotherapy, use a combination and hit it early. That's a thing I want to zoom in a little bit more now. If the LDH is normal, and possibly also in the adjuvant setting, and Daniel is going to talk about that a little bit later. So some data we have generated, or Novartis has generated in the phase 2 study, which is a study which was already performed in 2011, 2012, where we have a very long follow-up of the dabra-trami combination. And you see that here is overall survival shown, that roughly 1/3 of the patients are still alive after 5 years. And I think that's a very impressive and interesting result. Here are some endpoints, response rates for the combinations, and you see that the responses are high. We have complete response rates for the combination, which are in the range between 13 to 16%, and the partial responders are in the range of 50-53%. So that's a very high response rate, which is around 15% higher than the monotherapy. And also the duration of the response is prolonged to more than a year, around 14 months, 13 to 14 months, in comparison to 7 to 10 months for the monotherapy. And this translates also in overall survival curves, and this is an overlay of COMBI-V and COMBI-D survival curves, that this is highly reproducible. So you see a 2-year survival rate of 53% for the combination of dabra and trami, and 45% after 3 years patient alive. And this is obviously superior than the survival rates after 2 and 3 years with a monotherapy. What is also important is quality of life. And you see here that patients who got treated with a combination, whether you're looking at the COMBI-V or the COMBI-D quality of life measurements, that always the combination is doing better than the monotherapy, which is also associated with clinical activity, but also the side effects of the monotherapy we have seen over the years. To sum up, I think till very recently, metastatic melanoma was a deadly disease with a median overall survival time in the range of 8 months. Over the last 10 years, dramatic changes have taken place. We have discovered BRAF mutant melanoma being sensitive to BRAF inhibitor monotherapy, prolonging already overall survival time. And now the combination, the dual MAP kinase inhibition, is prolonging survival to more than 26 months. And tumor control is achieved in more than a year in these patients. I think this is a dramatic step forward. And there are, as I have shown you with the phase 2 data already, some patients who have a long-term benefit using this targeted therapy. Let's have a closer look. So already here, looking at survival after 2 years, you see there is a subset of patients in this meta-analysis of the phase 2 study and both phase 3 studies. There is a subgroup of patients who is surviving 2 years and way longer. So do we have any clue what are these patients who are benefiting from this kind of treatment? So there are a lot of tumor markers which have been tested and can be tested for this kind of treatment. None of these tumor markers really is telling. I think the best thing we have is LDH at baseline if this patient is sitting in front of you. And you see that even in this early trial, if you have elevated LDH, your 5-year progression-free survival time is 0. For those having a normal LDH, roughly 1/4 of the patient is still in control after 5 years. And obviously this also translates in overall survival. Normal LDH, roughly 50% of these patients are still alive after 5 years. I think this is a very interesting observation, and therefore it's important to treat these patients early as long as the LDH is normal. And obviously all the overall survival rates we are seeing in the clinical trials are driven by those patients with a low risk profile. And those patients with a low risk profile are those patients with normal LDH and limited tumor burden and with organ sites which are only involved in 1 or 2 of the organs which are involved. And I will show you this analysis in a moment. So obviously, this is a patient cohort which was always selected also for those treatments like ipilimumab, where we know that the efficacy is quite limited. So I think the likelihood that long-term survival we are seeing in our clinical trial data, whether we are treating with targeted therapy or whether we are treating with PD-1 monotherapy, is benefiting the same patient cohort, this low-risk patient cohort. So, and I think we need to think differently in order to come to the next level in our treating melanoma patients. So this algorithm, decision tree algorithm, you might have seen Georgina Long with the group has worked on that over the last years. It was published in Lancet Oncology 2 years ago, and this again summarizes the COMBI-D, COMBI-V, and the phase 1/2 data patients. And you see more than 600 patients were analyzed in this meta-analysis. And the results are quite simple. If you look at the clinical parameters, normal LDH is a very strong predictor in comparison to elevated LDH. And you see, with elevated LDH, your 3-year survival rate is just below 10%. In comparison, 3-year overall survival rate for those patients with normal LDH is close to 60%. And you can go even more granular. If you look, for example, in patients having only 1 or 2 organ sites involved, then your 3-year overall survival chance is almost 70%. And on the other hand, if you have 2-fold elevated LDH at start of systemic treatment, you are not even have a 10% chance to reach 2 years. So obviously, strong clinical factors, you don't need any biomarker to dissect your tumor or your patient's immune system. It's all sitting in front of you, and it's easy to decide. And here are some of the clinical data we have. And you see for the Combi D, overall survival in PFS is shown here. Survival on that left part, you see for those patients positively selected, normal LDH, only 1 or 2 organ sites involved like lung and lymph nodes, you see the overall survival time is not even reached. And after 3 years, almost 2/3 of the patients are still alive with a combination DAPRA-TRAMI. Progression-free survival, almost 40% of the patients are still in control. I think clearly demonstrating that there is a strong effect on this selected patient population. So to put it even more simply, I think patient with normal LDH already with the drugs we have in hand now, I think the chances to survive 5 years, it's gone. It's 50%, and for those patients having elevated LDH, we have still very high medical need, and we need more treatment options in those patients. And there are clinical trials trying to address this high clinical need, which includes also patients with brain metastasis or other locations, obviously. So to summarize the part of metastatic melanoma, and this is shown here, you see 3-year overall survival rates with the alkylating chemotherapy around 10%. Ipilimumab after 3 years, roughly 20% are alive. Monotherapy of BRAF inhibitors, around 30% of patients are still alive after 3 years. With the PD-1 antibodies and also DAPRA-TRAMI, after 3 years, roughly 50% of the patients are alive. So that's actually what we have achieved over the last years. And still, one has to keep in mind, looking at that obviously this is based on clinical trial data and clinical trials selecting patients, inclusion-exclusion criteria, and this might not be completely reflective of the real-world patients sitting in front of you. So there's an interesting aspect which is also giving some food for thoughts for future trial designs, and this is derived from the Combi D study, which has analyzed not only the BRAF mutation but also the whole genome sequencing. And one of the features which were shown were actually the fact that tumor mutational burden, which is associated with better outcome to checkpoint inhibition, for example, in some of the other tumors, is also associated with better outcome to DAPRA and TRAMI in this clinical trial. So I think we need to look into that more careful to see whether there is an interaction between the immune system and targeted therapy over the next months and years. So to close my presentation, I think I want to highlight some of the needs we have. And obviously adjuvant therapy is a new option using checkpoint blockade, but also DAPRA and TRAMI. And there is a huge need, as you see here, stage 3 melanoma patients, lymph node involvement in different ways, that these patients are going to die in a large percentage, and you see after 10 years up to 70% in the 3C category. These are the patients who definitely need adjuvant treatment in order to prevent migration into stage 4. And we had a first clinical trial which was positive using high-dose ipilimumab, an EOTC study which was testing stage 3 melanoma patients. And you see after 3 years there was a 10% benefit in relapse-free survival after 5 years in favor of high-dose ipi in comparison to placebo, and 10% in overall survival, 54 to 65% using high-dose ipi. The problem is that there was a lot of toxicity with this high-dose ipilimumab treatment. And so high-dose ipi was never applied to or never approved in Europe, only in the US. But we have now options, and I think this is the relapse-free survival curve of the COMBI-ID study, which is going to be presented by Daniel later on. But you see, after 4 years, there is a certain stabilization, and you have still more than 15% difference in favor of targeted therapy, although all these patients have been treated only for 1 year. And also looking at Checkmate 238, the adjuvant trial in stage 3 using nivolumab, you see that there is a benefit for those patients, but there is almost no difference whether you are treating patient with BRAF wild type and BRAF mutant. Possibly these patients are doing even worse with checkpoint blockade using nivolumab, giving a good option for those patients also with targeted therapy. And this is the third agent which has been tested in the adjuvant setting. The follow-up for this study is not 4 years, it's just a year. But you see also that also using pembrolizumab in comparison to placebo, there is a strong effect you're going to see. And there is always obviously some, if you compare the BRAF to BRAF wild type, obviously there could be an argument for using targeted therapy in these patients as well. So just one thing to keep in mind, choosing patients with adjuvant therapy. One of the arguments Daniel is going to discuss is treatment discontinuation. But, and this is for COMBI-ID, we know that this 1 year of treatment is in around 62% of the patients who finish this 1 year of treatment. And this is actually the same for the Nivo trial. Also, only roughly 60% of patients continue for 1 year and finish this 1 year of treatment. The difference is that 25 or 26% of the patients in the COMBI-ID patients discontinued because of toxicity. We are going to see that in more detail. And for those patients who got started on Nivo, 27% of the patients discontinued because of disease progression. Here, it's only 5% of patients who discontinued because of disease progression using dapagliflozin. So, I mean, this could be one of the algorithms which could be used in adjuvant treatment later on. I'm happy to discuss that with you, that you are looking also for BRAF mutation early on and to see what is the best option for those patients. And obviously, dapagliflozin is an excellent option where we have already long-term follow-up and overall survival data. And we are going to see more data on that study in a minute. And to summarize my presentation, I think the combination of a BRAF and a MEK inhibitor provides a reliable and fast clinical response in the majority of our patients, at least 65% in the metastatic setting. The duration of the response, the progression-free survival time, the median PFS does not differ between BRAF inhibition and PD-1 therapy. BRAF and MEK inhibition achieves also a long-term tumor control, and OS is comparable to a checkpoint blockade after 3 years. There might be also a long-term benefit which is mediated by immunological mode of action. We have learned over the last years that patients with normal LDH at treatment start in stage 4, that this cohort has a good chance to have a long-term benefit of being treated with also targeted therapy, which is ranging in the of 50% after 5 years. There might be also an association of mutational load or tumor mutational burden associated with targeted therapy. And the new options we have with adjuvant therapies in stage 3 is also likely to increase melanoma-specific survival overall, which is, I think, good news for our patients. And obviously, access to targeted therapy and checkpoint inhibitors will influence also treatment choices in first line of stage 4. So that's actually something we have only ideas but no data, which will be probably an interesting topic for discussion over the next years. So I believe that we will see increasing 5 and 10-year survival rates for melanoma, which is also helped by the adjuvant options. More and more treatment decisions in stage 4 will be dependent on other parameters, comorbidities, for example, life expectancy, and toxicity profiles will only come into play if efficacy is not different. The greatest progress has been made in patients with normal LDH, and we have to remember that still today, still in 2018, patients with elevated LDH, only 10% will survive 3 years. And obviously we need more and other options, including different scheduling, run-in, sequencing, new agents, in order to make any progress in these patient cohorts. And on the other hand, patients with normal LDH and long-term benefit, those are those patients who can dream that they are achieving cure in the future. So I think in order to make progress nowadays, it will take much longer because obviously patients are living longer, and even median PFS is now approaching 2 years. So we are missing reliable surrogate markers in order to speed up clinical development and to estimate also long-term and long-time benefit. And we have many questions. I mean, we have made some progress, but we still have many questions on the duration of therapy, combination versus sequence, treatment until progression, or possibly also earlier switch, or how can we stop treatment, and which patient cohort is benefiting most from what we can offer. And we need to get away from gut feelings and need more clinical outcome data in order to advance the outcome of our patients. So there are still trial activities and clinical studies, which I think is good news, but we have to be patient in order to establish new and the best treatment options for our patients. Thank you for your attention, and we have still some minutes left for your questions. Thank you very much.
Thank you very much, Dirk, for the wonderful overview of treatment of melanoma. It's a really fantastic decade we had. Уважаемые коллеги, у кого есть какие-то вопросы, пожалуйста, не стесняйтесь, подходите, это редкая возможность задать вопросы эксперту такого уровня. Любые вопросы, я думаю, будут с удовольствием отвечены. Пожалуйста.
Is it effective to use MEK inhibitors if we find NRAS mutation in melanoma?
Good question. So we have seen a large clinical trial, NEMO, which used a MEK inhibitor, a different one, not trametinib, binimetinib, as a monotherapy in NRAS mutant melanoma patients. And the overall survival in comparison to alkylating agent DTIC was not different, not at all. So I think there is no reason to use monotherapy of a MEK inhibitor in those patients. There is currently a clinical trial testing patients who are BRAF wild type, including patients who are NRAS mutant, using a MEK inhibitor plus checkpoint blockade, as it has been done in colon cancer, and I think there's also a study in lung cancer. And the early clinical data which are available, phase 1-2 studies, is demonstrating that the progression-free survival of checkpoint inhibition and a MEK inhibitor is prolonged to 15 months. However, these are only 20 patients, so we have to wait. So there is a registration study testing that pembrolizumab against BRAF, against a checkpoint inhibitor plus a MEK inhibitor. And this study had full recruitment last week, but probably we have to wait till the end of next year to see and to know.
Thank you.
Спасибо. Есть еще вопросы? Дирк, я по-русски буду задавать. Вот если есть пациент, у которого высокий в ЛДГ выше нормы, но при этом это очень хороший функциональный статус, ЭКОК 0, несколько сайтов метастатических, включая, допустим, легкие, печень. Какой предпочтительный вариант, есть BRAF-мутация, какую предпочтительную терапию вы выберете? Проведение таргетной терапии, иммунотерапии, монотерапии, антипедиадин препаратом или комбинированной иммунотерапии. Все-таки это один из самых сложных выборов на сегодняшний день, и это частая, к сожалению, ситуация в нашей обычной клинической практике.
Yeah, I completely agree. A challenging situation, especially a challenging situation since we are here with Novartis and talking about targeted therapy. But to be honest, probably our first choice in many cases would be Nivo-Epi. Although we know that the response rates are lower, but we have seen some promising results. On the other hand, we know that BRAF-MEK combination, dapatrami for example, has a chance also in a large subset of these patients, you know, coping the symptoms, but your patient was ECOG 0, so there are no symptoms. Huh? So, I mean, especially in symptomatic patients, we would go for a BRAF-MEK combination. The problem is, and I have not shown the data, that the duration of the response, the progression-free survival time with targeted therapy is much shorter. And the question is, in real world, if you start with targeted therapy, how long would you then go with targeted therapy? And what are the indications that you would switch to a possibly maintenance checkpoint blockade? There are no real good data, that's what I said. We have clinical trials testing this concept of run-in with targeted therapy for 2 months, 3 months, or 6 months, and then switch and maintain with checkpoint blockade, or have some sort of triple combination, which is also possible, because obviously the disadvantage of checkpoint blockade is if you are not achieving a response, particularly a complete response, you might lose the tumor control. And patients like you have described is always a challenging situation for all interdisciplinary tumor board discussions, you know, what to deal with. And I mean, obviously factors like quality of life, comorbidities, age of the patients, distance to the center. Is the patient able to come with severe side effects to the center, will also play into a decision-making process.
Okay, thank you very much for this wonderful answer. Доктора, пожалуйста.
Спасибо большое за интересный доклад. Скажите, пожалуйста, метастатическая меланома, ЛДГ в норме. Полный ответ. Какая продолжительность иммунотерапии?
Таргетная терапия.
Иммунотерапия.
Продолжительность иммунотерапии.
Okay, so I think we should answer this question, complete response, and how long should you continue treatment for targeted therapy and for immune therapy? Huh? I think our practice, so there are no data actually. I mean, there are only retrospective data trying to make sense of what I'm telling you. So our practice in our center, I can tell you, for checkpoint blockade, if we see a complete response, we try to validate that 12 weeks later. And if there is still a complete response, we would stop treatment with a checkpoint blockade. This is possible because we can, in Germany, re-challenge these patients, retreat these patients if a patient would have a relapse, let's say, 2 years later. In some of the other European countries, this is not possible. England, Italy, so you have to exhaust your treatment line. So in Germany, we could stop and wait and then retreat if necessary. For targeted therapy, we have data that a complete response, that roughly 50% of patients will lose their complete response over time. So after 3 years, roughly 50% of the patients have lost their complete response and have progressed. Based on the clinical data and a retrospective analysis of the studies I have shown you, COMBI-D, COMBI-V. So what we don't know is how long these patients have been on treatment. So what we do in our center with targeted therapy, we leave these patients much longer on treatment after we have validated the complete response, usually a year. So we keep on treating these patients with a complete response for a year, and then if the patient wants to stop, we stop. Also with a chance to restart treatment if possible. And we have quite a number of patients where we were able to stop treatment after a complete response. But I have to admit that some of these patients have been on treatment for 2 or 3 years before we have stopped treatment. And if you are in doubt, it's also helpful to do a PET-CT. So if there's any activity which you and your radiologist are not able to discriminate, what is this? PET-CT, I don't know how you do it in your center, Daniel, and whether you have access to PET-CT. Then in my experience, it's a good option. And if there is some activity, ask the surgeon to go after it and to see, is it immune system still at work, or is it still remaining tumor left?
У нас есть еще вопросы, доктора? Thank you very much, Dirk, for a wonderful presentation.